So welcome to the schizophrenia session. The first presenter, Samuel Knight. Who is your supervisor, Samuel?
That would be me.
Great. So Gemma, welcome. Over to you to introduce your scholar.
Thank you very much. I'm Gemma Molinos from the Institute of Psychiatry at King's College London, and I'm delighted to introduce Sam's talk this morning. Sam started his studentship in October 2020 in the midst of it all, so the main project was stopped at that time, and he's used this time really to train in the methods involved. It's quite a brain imaging heavy project that he'll explain in a minute. And he's also just finished writing a comprehensive literature review relevant to his topic. So over to you, Sam, and I hope you all enjoy the presentation. Thank you.
All right, thanks very much, Gemma. Can everyone see my screen okay? Can you hear me okay?
Yes, we can.
Okay, great. So I'm just going to launch right in talking about my PhD project, which is the neuromechanisms of positive symptoms in first episode and prodromal psychosis. So just a quick outline. First, I'm going to give a bit of a background of what that actually means, some of the key questions that come from that, how we're trying to investigate those questions, what we think is going to happen, and then touch on the progress that I've made so far in this first year and a bit. So what is psychosis? Well, psychosis is a very severe mental state, and we tend to categorize psychosis by clustering it around these different symptom categories. And I'm going to be focusing mainly on the positive symptoms because it's most relevant to my PhD. That includes delusions, hallucinations, persecution, things of this nature. But just to acknowledge as well that psychosis also includes these other symptoms, these cognitive deficits and these negative symptoms. Now, psychotic disorders usually have an onset in early adulthood, affect roughly 1% of the population, and there's really high costs associated with them, both for the outcome of the individual, but then also for the societal costs. So as I start to talk about, the neural mechanisms of psychosis, don't worry too much about remembering this brain region doing this and that sort of thing. But what I'd hopefully like to communicate is just the logic of how we're trying to investigate these questions. So the positive symptoms of psychosis at the moment, currently the best explanation for why these symptoms arise is because of dopamine dysregulation. Dopamine is probably a neurotransmitter that you've heard of. It's involved in reinforcing signaling. And what we think is going on in psychotic symptoms, positive psychotic symptoms, is there's an aberrant salience. There's irregular dopamine reinforcement, and that's causing people to pay more attention to things they shouldn't be paying attention to in a very basic sense. And currently, the way we treat psychosis is with antipsychotic drugs targeting this dysfunction. And that's pretty good for a lot of people at reducing the positive symptoms, but it also doesn't work for a lot of people. People might still have persistent symptoms, lots of nasty side effects. So dopamine isn't the entire story here. And so what we're trying to investigate is really things that are happening upstream in the brain, rather than focusing on the dopamine dysfunction, focusing on other regions that might be contributing upstream. And two of these regions are the prefrontal cortex and the hippocampus, which I'm going to pay the most attention to. And so the way that these brain regions communicate to each other is a balance between excitatory and inhibitory signaling. We have positive excitatory pyramidal cells and inhibitory GABAergic, predominantly, interneurons. And the balance between this excitatory inhibitory firing is really important for brain regions to talk to each other effectively. And one of the things that we think is happening in psychosis is that there is an imbalance between the signaling. One of the reasons why this might be is what we call oxidative stress. So anytime you're using energy in your body, there are byproducts to that reaction. You've probably heard of free radicals, you've probably heard of antioxidants, and free radicals or reactive oxygen species, our body does a pretty good job of mopping these up after we use energy. But if certain regions become hyperactive, become more metabolically active, there's more byproducts, and these aren't necessarily taken care of. And the cells that are most vulnerable to this sort of dysfunction are these inhibitory cells, which are really important at coordinating these neural firings between the different regions. So what we think is happening in psychosis is oxidative stress is damaging these interneurons, causing an increase in activity in the hippocampus and then increase in activity in downstream regions and aberrant salience. So the key questions really for my PhD is, can we find signs of the hippocampus being hyperactive in psychosis? Can we find signs that there's an imbalance between excitatory and inhibitory signaling? And can we find signs of redox imbalance or oxidative stress? So now I'm going to shift and talk a little bit about the progress made so far and the methods that we're using. So my project is part of the larger stress gap project being conducted by my lab. And we're looking at really at three patient populations, well, three populations: healthy control participants, people at clinical high risk for psychosis. These are people that don't have a psychotic disorder, but they do have attenuated positive symptoms. So we think that they're at the highest risk for somewhere down the line developing a psychotic disorder. And then we're also looking at people experiencing first episode psychosis. These are people that are currently have positive psychotic symptoms. And the procedure goes like this. I've embedded myself within different teams within South East London and early intervention services, and I speak to the care coordinators there about people that may be interested in participating in research. Having done this now for a year, I can say that people want to participate in this research for all sorts of different reasons. Some people just like a little bit of extra money. Some people are really interested in just trying to know what's going on with them and trying to understand a little bit better the changes that they're going through and the stressful experiences that they're going through. And other people, which is really interesting, it has been interesting for me, is just people want to help, even if it's not benefiting them directly. They want to provide researchers with more knowledge so that these problems that they're going through might be better dealt with people in the future. And I think that's really powerful. So once we've identified people to come in and go through the rest of the procedure, we get them to come in, we do some clinical questionnaires, we do some cognitive assessments, and we take a blood test as well, which allows us to take a little bit of genetic information, which we're going to look at later relating to oxidative stress, but I'm not really going to talk too much about that today. And then we get them to do a PET MRI scan. And the MRI aspect of the scan is really the important bit for me, but just to acknowledge as well that we do also do a PET scan at the same time. So it's a little bit more of an invasive scan than some people are used to. So it's really amazing that they're willing to go through this process. And we're normally done within 2 to 4 weeks. So as I said, I'm really using these two MRI-derived component methodologies. One is arterial spin labeling, which just gives us a resting metabolism of the hippocampus. So that's going to show us whether we find signs of hippocampal hyperactivity. The other is what's called magnetic resonance spectroscopy. It's a slightly different application of the magnetic resonance phenomena. It allows us to look at the concentration of a particular metabolite that we're interested in our case, this GABA, this inhibitory neurotransmitter, and glutathione, which is the body's main antioxidant. And we're able to look at the concentration of those metabolites in a particular region. And you can see that's an image from one of the participants that we have there. So what we think is going to happen is in the early psychosis group and also in the people at highest risk for psychosis, we're going to find signs of hippocampal hyperactivity. We're going to find signs of this excitatory inhibitory balance being abnormal. And we're going to find signs that the redox balance of these patients is abnormal, they'll have less glutathione. So other than the participant recruitment that we've gone through, which I sort of flash past it a little bit, but you can see how many we have in each group so far. Obviously, recruitment has been slowed down because of the pandemic, but we are in full swing at the moment, and things are going. We're hoping that will be all done in time for me. Other than that, I've been going through various training relating to the methodologies, and also writing this literature review that Gemma mentioned. So this is something I've just submitted, and it's looking at the neurodevelopmental trajectory of the hippocampus and why that region in particular might be vulnerable to dysfunction and the sort of dysfunction that we see in psychosis. I then talk about the hippocampal abnormalities that we find in psychosis and those at risk for psychosis, before talking about the ways in which those abnormalities might be targeted by specific interventions. So you can see from this graph antipsychotic interventions come quite late after someone's already experienced first episode psychosis. And so if we can focus on earlier treatments, we might be able to attenuate or prevent entirely the development of psychosis. And that's really why this research is important, because if we're able to uncover more about these neuromechanisms, we might be able to come up with better treatments and be able to intervene earlier. So yeah, I'd just like to acknowledge Mental Health Research UK and my lab and my supervisor. And yeah, that's it.
Great, thank you very much. Could you take your slides down?
How do I stop? There we go.
Good, so we've got some questions. Trevor.
Oh, yes, nice presentation. I wonder whether you're able to also quantify glutamate, because you were talking about the excitatory inhibitory balance.
Yeah.
But you're only looking at one part of that, which is the GABA levels.
Yeah.
Are you measuring at 3 Tesla or what?
Yeah, exactly. At 3 Tesla. We do have another MRS voxel in the same region that the one I sort of showed in my slides is. The sequence that I'm mostly focusing on for my PhD is looking at GABA and glutathione, but we do have a press voxel in the same area or a very similar area so we can get a measure of glutamate as well there.
Okay, thank you.
Thanks, Trevor. And James?
Hi, Samuel. Thanks for the talk. It was really interesting, and I wish someone had explained the sort of basic neurobiology of how dopamine and the hippocampus and the striatum and so forth fitted together when I was a student, because it's something I've always struggled with as an epidemiologist. So my question was really just a bit of clarification about that. So it makes perfect sense that you said that you want to look at kind of upstream things, upstream of dopamine, but presumably if you find that there are these changes in the hippocampus that are important in psychosis, then they don't necessarily even need to go through the dopamine system. Is that right?
Yeah, that's absolutely right. So, I mean, dopamine is part of the picture for some people, it seems, but it's not to say that it's the whole story at all. Because hippocampal abnormalities, part of the reason why we're looking at 3 groups and people not just having psychosis, but people before the development of psychosis is, if we can find abnormalities in these systems that, are prior to any dopamine abnormalities, we can better characterize how that might be targeted earlier. And, there are many other interpretations that of all positive symptoms, but particularly the negative symptoms in other aspects that don't have anything to do with dopamine, but may still have something to do with hippocampal hyperactivity.
Right. Great. Thank you very much. I really look forward to seeing the results as they come out in the next couple of years.
Yeah, good luck with recruitment. We've got 2 more questions. Juliana's first, then Laura.
Thank you. Great presentation, Samuel. So it's really nice. I'm always really interested in these types of studies. I say these types of studies, you always get different groups, and just because you'd mentioned before, which I thought was really helpful, about the different reasons why people get involved in research. And nothing else to do, or money, all those things. But I was just wondering, in terms of I don't know, the user voice, in terms of just the area that you're focusing on and what they think about that.
Yeah, I mean, it's really tricky, the way that we recruit is primarily through speaking with care coordinators, and it can be really tricky, I guess, to get direct input from patients. As we communicate about the study, every individual client will have different concerns, different things that they raise, different ways of thinking about what's going on for them. Psychosis is one label that we use, but often I find, speaking to patients, it's more useful just talking about the stressful experiences that they're going through now, rather than using these labels. So that's one thing that I've learned, is speaking to patients. Yeah, I don't know. That's about all the answer I have. Sorry.
No, it's just that the reason I mentioned it, because I just think people start to make these distinctions and they're somewhat artificial. This is such important research, and the idea about what it can kind of lead to. But I often wonder, well, I see it a lot of the times, that even though people might get involved, but they don't always understand why.
Yeah.
What it's about and what you're trying to do. And
we do try to, you know, at many points along the line, really try and outline, you know, as clearly as we can, and we do have criteria around what we believe to be a certain level of capacity for people to be able to consent as well, because it is a little bit of an invasive study. You know, the PET side of things, they have to have an arterial line at the wrist. They're injected with a radio tracer. That can be a quite stressful experience for some people. So, you know, we do try and, you know, outline, you know, many points along the way, what's involved with the study, the benefits, the risks of taking part, you know, and you know, that it's not, this is not a clinical scan. You know, we're not going to be able to tell anything about your brain specifically. You know, we do outline that up front to people.
It is a really important point. Thanks for making it, Juliana. We've just about up to time, but Laura Davidson, can you fit the question and Sam, your answer in under a minute?
I will do my best. Hi, Sam, thanks again for your presentation. I'm just turning on my video briefly because my connection here is a bit unstable in Africa. My question really, you may not be able to answer it. You said that one of the groups was for people with attenuated positive symptoms, and then there are obviously people with positive symptoms. But the dividing line between the two is a little tricky. How are you deciding on the diagnoses? Also, surely there may be an issue where possibly they go over the line and then they are actually diagnosed as psychotic or having schizophrenia during the trial, and how would you deal with that?
Yeah, it's a good question. I mean, our primary dividing line between these patients is the groups that we recruit them from. So early intervention services in the case of First Episode, and the Oasis service in South London for the clinical high risk. Now, within that clinical high risk service, there is, you know, we administer the CARMS questionnaire to them, and that does have, you know, a level of symptom threshold that would be over our limit for that group, and that I'm not aware of any specific instances in our recruitment that has occurred, but yeah, that is essentially our dividing line. You know, we during the clinical interview stage, we establish, you know, we question them about their experiences and score them based upon that.
Thanks, Sam. I better draw you to a close there. Thank you very much for a great talk, and look forward to next year.
And I'm happy to answer more about that question, Laura, in a private chat.
Okay.
Thank you.
Let's move on to our next speaker, Jessica Radley, and Jessica is supervised by Louise Johns. Louise, are you there to make an introduction?
Yeah, I am.
Great.
Okay, so can you hear me?
Yes.
Yeah, so I'm delighted to introduce Jess Radley. So she's a fourth year PhD student at the University of Oxford, and her thesis has examined the needs and experiences of parents with psychosis and their families. So she's used a mixed methods approach. So she started with qualitative interviews with parents with psychosis and also with their children and other family members. And she also conducted focus groups with mental health professionals working with these families. And she presented these results at the conference we had in Cardiff. And she's also analysed quantitative data from NHS Trust electronic health records to examine the frequency of parenthood in patients with psychosis and then the associated characteristics and risk of relapse in this group. And then she presented these results last year. She's also done 2 systematic reviews, a Cochrane review and a broader scoping review. And then the qualitative studies study led to the design of an experience sampling methodology study to look at the relationship between parenting stress and psychotic symptoms. And Jess is presenting those results today. So just to say, I mean, Jess has worked extremely hard during her PhD. She submitted 8 research papers, 6 of which are published or accepted already to under review. She's been committed to open science, publishing things on the Open Science Framework, a registered report, and to patient involvement throughout her studies, done some excellent PPI, particularly with this study. It's been an absolute pleasure to supervise her. She'll be submitting in July her thesis and then starting clinical psychology training in the autumn, and hopes to pursue a clinical academic career. So I'll hand over to Jess.
Thank you very much, Louise. Yes, so as Louise has said, my PhD has been looking at the needs and experiences of parents with psychosis. And I've done that with 4 main areas of research. So a secondary data analysis of parent characteristics. So what makes you more likely to be a parent when you have psychosis? Some qualitative interviews and focus groups with the parents themselves, with their partners, with children, with mental health professionals who have worked with parents with psychosis. And I've conducted some systematic reviews of interventions to actually think, what's out there to help these parents and what more do we need to do to develop good interventions. But today I'm presenting the results from an intensive longitudinal assessment of stress and psychosis. I'll just present that now. So we know that stress plays an important role in the development and the maintenance of psychotic symptoms. And there's a stress vulnerability hypothesis of psychosis, and often you can use this bucket analogy. So we all have different vulnerability to psychosis due to genetics and early life experiences, and some people have a much smaller bucket. And so the water in the bucket is stress. So some people need less stress for their bucket to overflow into psychosis, but some people who don't even have much vulnerability may experience lots of stress throughout life and still experience psychosis. So that's quite a key hypothesis in the field of psychosis. We also know that the pathway from stress to psychosis may be through something called negative affect, but I'll just be using the term low mood today. So it might be that stress leads to low mood, which then leads to psychosis. And finally, thinking about my research, well, we also know that parenting is a really stressful job. And so I want to investigate what's the relationship between stress and psychosis like in parents, or specifically stress due to parenting. So I had 3 hypotheses. First of all, that stress due to parenting will increase psychosis, and that will be mediated by low mood, which has been found in the literature before. Secondly, that the factors in this box will all improve the model's estimation. So parents' levels of social support, their levels of coping, their perception of their child's behavior and their own self-efficacy will influence this relationship between stress and psychosis. And then finally, that stress specific to parenting, so stress due to parenting, will have a larger impact on psychosis than stress in general for these parents. So the eligibility criteria was that they had to have a diagnosis of psychotic disorder, but excluding ones where the cause would be non-stress related, so things like postpartum or drug-induced or organic. They had to be a parent of a child between the ages of 2 and 16, and they had to live with their child so that we could measure parenting stress. And a power analysis returned that we needed to recruit 32 participants. So we used experience sampling methodology as a design, which is a type of intensive longitudinal sampling of participants, where you give them the same survey multiple times over a short time period. So the advantage of this is that you get multiple measurements, and in particular, it's good for factors that change often. So mood changes often. So if you measure someone's mood at one time point, you might not be getting the full picture of their mood in general. And you often ask people to take a study phone home, or they install an app on their own phone. So another advantage is that you're measuring them in a natural setting rather than a lab-based environment. So that's what we did. We asked participants to take a study phone home that only had one app on it, which was this app that would sample them, and it would beep several times a day. So it beeped 6 times a day over 10 days. And when it beeped, these 20 questions would pop up. This is kind of what it looked like. So I feel lonely was a type of low mood question. So they'd get the question on their phone, I feel lonely. And they would swipe between 0 and 100 to indicate how much they agreed with that. Those were our time varying questions, our experience sampling methodology questions, which we imagined their answer would change throughout the study. And then we had these time invariant questions, so things like demographics, or those items I measured earlier, so social support and coping. And we measured them at one time point, so at the beginning of the study. And statistical analysis, for those who are interested, is called multi-level regression, because you have these multiple time points and you need to group them within people. And also to say that had some public and patient involvement in the study. It was quite important because it's a slightly invasive study. They're taking phones home and it's beeping all the time. So I really wanted to, I gave people, we had a day in Oxford, we invited 4 parents of psychosis to try out the mobile phones. We talked about some of the questions that would pop up, and they gave me some great advice and great ways to change the study. So things like, don't phrase everything negatively. Don't have every question that I feel sad, I feel lonely. You can phrase some questions positively and then reverse code it later. Or, don't beat me at certain times of the day. And I wouldn't know that because I'm not a parent myself. So it was really useful to get that input. So onto the results. So characteristics. So we actually ended up recruiting 35 people. Most parents in the sample were mothers, most people were female. Most people were white British, probably because we're recruiting from Oxfordshire. Most people were married or had ever been married, but 7 people in the sample were single. Average age was 41. Most people had their first psychotic episode at 36, 37, which is actually quite late, which is interesting. And the number of children on average was about 2.4, slightly higher than the national average. And just for interest, here's a kind of a snapshot of 10 participants' psychosis scores throughout the study. So you can see along the bottom here, you have the 60 observations because we sampled them 6 times a day for 10 days. And up here is the psychosis scores. So you can see for some people, they reported quite high levels of psychosis, like the number 32. With participant 2 and 4, they reported quite low levels. Some people had much more variability, like in 32, but some people were a bit flatter, like in 4, so not much change between his or her scores. You can see participant 34 had a bit of a trajectory throughout it. So they started fairly high and it kind of leveled off throughout the study. And some people recorded lots of beeps, like number 4, number 22, or some people recorded fewer, so number 28, seemingly only recorded about maybe above 20 beeps. And if they recorded fewer than 20 beeps, they were excluded from the sample, and that only happened from the analysis, and that only happened to 1 person. So the first hypothesis, so stress due to parenting will increase psychosis, and that being mediated through low mood. So the model did seem to be the case. Just to visually represent that, you can see the positive relationship between parenting stress and psychosis. And looking at low mood as a mediator, so this top line, the causal mediation effect, which is these solid red arrows, that was highly significant, the causal effect. And it was so significant that actually the direct effect, this kind of shaded red arrow here, became non-significant. So it implied that actually the relationship between stress and psychosis was being fully mediated by low mood. And then just showing you the same graph now, but colored by low mood, you can kind of see that. So people with the highest scores of low mood did have very high levels of psychosis. And then those with less low mood are down here in blue. So you can kind of see that relationship visually. And this was the final model. We also included participants' mean level of stress and their mean low mood throughout the study. So that is, we'd have up to 60 beeps per participant. So we take their average of stress and low mood that they experienced at the whole study and put those in the model too. And those were also highly significant in a positive direction, showing that the more stress they experienced in general, the more low mood they experienced in general led to more psychosis. And age and gender weren't significant in the modeling of the relationship between stress and psychosis. So in the second hypothesis, so we added in these 4 factors, and there just didn't seem to be any significant effect there. We also investigated them not just as covariates, but as moderators, and there was some relationships there, but I don't really have time to talk about it now. But yeah, it is interesting that there wasn't much improvement in the model estimation. And then the third hypothesis, that stress due to parenting will have a large impact on psychosis and general stress. I'll first just briefly touch upon how we measure stress. So we asked them what they're doing right now. And one option was parenting activity, and they had all the other things they could tick. And then we asked them, we got the amount of stress question, the stress score. So they said, I'd rather do something else, it's difficult for me, or I can do this well. So you reverse code, I can do this well, and then take an average of these three. So we classified parenting stress or stress due to parenting as any time they clicked parenting activity and then their stress score. And other related parenting was times they hadn't clicked parenting activity, they clicked something else. So that actually was a significant effect of type of stress, but not in the direction we thought. And it's very subtle, but you can see here that actually the other related stress line is just slightly steeper than the parenting stress line, just slightly. And that was significant in the modeling. So we didn't find that parenting stress did have a stronger relationship between stress and psychosis than other related stress. It was actually the opposite effect, but not in a major way. So to conclude, parenting stress does exacerbate psychotic symptoms. So adding to the literature between stress and psychosis, parenting stress is important. Just thinking about parents with psychosis in particular, people often think about, well, when you have psychosis, how does that impact on your parenting? How does that impact on your children? But we also need to think about the other direction. Your parenting is really stressful. How does that impact on actually their mental health and how they're experiencing symptoms and how they can manage them? So I think it's really important to think about both these directions. Then again, we've confirmed that low mood is a really important mediator of this relationship. And finally, we didn't confirm that parenting stress was more impactful than other types of stress, but I really wonder whether it was possible to disentangle stress due to parenting. I mean, if you're a parent, then actually, work stress might be related to parenting too, because you might have less time to work, you might have to leave work early for certain reasons. So I think actually to really disentangle the effects of parenting stress, it'd be better to compare it to a group of non-parents with psychosis. Okay, so I'll wrap up. So just because I am about to hand in, I just want to highlight the publications, and this one at the top is related to this study. And as Louise said, I had it accepted as a registered report, which I was really pleased by, because they said as long as I collect the data, I had that done before I collected the data. So they said as long as I do exactly what I said I'd do, they published the results, no matter if it was a positive or a negative finding. And then I want to thank Mental Health Research UK for supporting me to go to the SIRS conference last week or 2 weeks ago, where I presented a poster. And then just thank you to my supervisors.
Brilliant. Thank you very much. Lovely and clear. Any comments or questions? Elvira.
Hello. Well done for all your papers and for this very interesting presentation. This is a very under-researched topic. It's really very exciting to hear. Sorry if you mentioned this already. I was wondering if you had looked at any treatment effects on your associations and on your modeling, both psychological and medication treatments, because of course a lot of patients get given treatments precisely for low mood that might perhaps modify these associations.
No, I didn't look at any treatment effects, actually. I can't really offer much insight into that question, but it's a very interesting question. And of course, it's going to have an impact. So yeah, I mean, it's definitely a field of work that'd be important to look into. But it kind of branched off from my thesis, which is what are the needs and experiences of psychosis. So it came out of this qualitative study where parents were saying some mothers, I almost had this hypothesis that some mothers developed psychosis so late in the sample, and particularly had children with really difficult behavioral needs like ADHD or ASD. And part of me was thinking, like, well, was parenting so stressful that it actually almost contributed to the development of psychosis in the first place? So that's why I really wanted to measure this relationship between stress and psychosis in parents with all these additional factors. So that's kind of where I came from with this idea. But looking at treatment effects would also be really, really interesting, particularly with low mood, like you said, to see if reducing that, did that reduce the levels of psychosis as well, if you kind of tackle that pathway. Yeah.
It's another PhD altogether.
Another PhD. Yeah.
This question about the specificity of parenting stress, if it is specific, might be something that you could get the views of parents themselves.
Yeah.
I mean, my recollection, and remember I was a father, not a mother, is that the whole life becomes quite stressful at times. And I'm not sure I could have parsed out specific aspects. Yeah,
no, I really agree. I think that's a good conclusion. And so the great thing is, as Louise said, us really into open science. All of the data is going on the open science framework. And I've been talking to someone at Manchester as well about, you don't need to recruit a group of, you don't need to rerun the study, just need to recruit a group of non-parents with psychosis, do the same study, and then you can compare the results. So hopefully the results from my study will be able to be compared to other groups. And I think that'll be better of disentangling the effects. So you've got two groups of people with psychosis, one have this job of parenting and one don't. Then what are the differences? What's the group effect? I think
that would be very neat.
Yeah.
And it's really nice to see you using the pre-registration system again. Another example. That's lovely.
Yeah. And it's great, and it's really important to think about it earlier on in your career, because it's a bit tricky to work your way through. And also, if you want to pre-register a study, you have to have, you know, the ethics approval in place. You have to have your introduction, your methods done and accepted before you can even start the study. So you have to front load it in your PhD.
Yeah.
Yeah, but I mean, I think
it's tough, but worthwhile.
Exactly.
Okay, well done. I think we better move on, because I'm not quite sure whether we finish 55 minutes after we started or at 12 o'clock. So thank you very much, Jessica. Let's now move on to our third speaker, Marianne Berea, who is supervised by Trevor Robbins.
Thank you, Peter. So it's a pleasure to introduce Marianne Berea, who's in the 4th year of her PhD. In fact, she's due to submit on May the 1st. And in addition, just to put a little more stress on this, she is due to take up a postdoctoral place following her thesis. And we think that this is going to be the first step of a very promising research career. Now, as you know, collecting in-person data, behavioral and neural, in difficult psychiatric groups has proved to be very challenging in the last couple of years. Marianne has risen to this challenge, and she's going to present some of the highlights of her recent findings, which I think you'll find very interesting and we think are highly publishable. Thank you.
Thank you so much, Trevor, for the introduction. So I'm going to share my slides. Can everyone see my slides? Okay, great. So my PhD work was on understanding the neurobiological mechanism of obsessive compulsive symptoms in schizophrenia patients caused by their medication clozapine. So about 25% of patients with schizophrenia, they are also diagnosed with comorbid OCD. And unfortunately, these patients, they tend to have a reduced social functioning, a higher suicidal risk. And in our 2019 paper, we actually reported that these patients have a higher positive and depressive symptoms. But besides the comorbid OCD, we have the drug-induced obsessive compulsive symptoms. And by far, the highest rates have been reported for clozapine. And this works possibly through the serotonin receptor antagonism. But in a more recent publication, we also reported that these symptoms, they impact patients' well-being, and this is independent from their schizophrenia symptoms. Despite the importance of this comorbidity, there haven't been many studies on the topic, and that's why I decided to study these patients during my PhD. But in this talk, I'm going to be focusing on checking, which appears to be one of the most common obsessive compulsive symptoms. And my initial work around this revolved around revising a new laboratory task to measure checking behavior. So we have tested around 100 participants for this study, divided into 4 groups of healthy volunteers, OCD, and 2 schizophrenia groups. They were both treated with clozapine. One group showed obsessive compulsive symptoms after the treatment, whereas the other one did not. And I did describe the checking task in my previous talk, and it is on YouTube. But very briefly, participants get to see 2 images, and they have to decide if these 2 images are the same or different. And they have the chance to check the images again to improve their answers. And when we look at the performance of all 4 groups, it is very clear in healthy volunteers that they didn't need checking to improve their performance because they were already performing very well. Whereas the 3 patient groups, they needed checking to improve the performance or accuracy of their answers. And it is very important, very interesting to note that only the schizo-OCS group amongst the three did not use the checking information to improve their accuracy. So they showed dysfunctional checking. And this dysfunctional checking, it was also correlated with their clozapine dose, but also executive functioning, such as a special working memory performance. And this is despite the fact that both schizophrenia groups, they were matched on these factors. So we were also interested to know more about the neural mechanism of these symptoms. And anterior cingulate cortex is a very important region for OCD, as previously shown. It is implicated in error correction, which is obviously very relevant for checking and in goal-directed behavior. But ACC is also an important region in schizophrenia. And thank you so much, Samuel, for the very nice introduction on inhibitory signaling. So there are studies showing reduced GABA levels in ACC of schizophrenia patients, and the effectiveness of medication being associated with GABA increase in ACC. And during my master's, I also found enhanced ACC activity in patients with a high genetic risk for schizophrenia. So it is very clear that ACC is a very important region to study, not only in OCD, but also in schizophrenia patients. And that is why we decided to study the neurometabolite ratios in ACC. Again, thank you, Samuel, for making this easier for me. We hypothesized finding higher glutamate, which is the main excitatory neurotransmitter in ACC, and lower GABA, which is the main inhibitory neurotransmitter. And we also hypothesized that these concentrations would be linked to obsessive compulsive symptoms. So this is just to show you the region that we were interested in. So this is the ACC region that we were interested in. And this is what we get to see after we acquire the data. So this line that you see here, it combines all the neurometabolites in that area together. And depending on the concentration of neurometabolites, their peaks will be higher or smaller. And unfortunately, the neurometabolites that we are interested in that are important for schizophrenia and OCD, such as GABA, glutamate, and glutamine, they have a much lower concentration. That is why their peaks are concealed or hidden underneath the metabolites with a larger peak, such as these ones. And in a recent review, I also found that GABA, glutamate, and glutamine, they have been very challenging to study in OCD using more conventional magnetic resonance spectroscopy methods with a lower resolution, usually ranging between 1 to 3 Tesla. And that is why we decided to use a 70 scanner to study the neural correlates of obsessive compulsive symptoms, because this enables us to dissociate these neurometabolites from each other. Because in most of the studies with a lower resolution of their magnet, they combine these neurometabolites so that it is easier to detect them. But with a 70 scanner, we can actually dissociate them and report them individually. So in the beginning, we aimed to test all 4 groups on the 70 scanner, but then the pandemic started and the recruitment was very challenging for all participants, but then especially for patients and especially for schizophrenia patients. And that's why we could not test schizophrenia patients on the 70 scanner. However, we did continue the study with OCD patients and healthy volunteers. And I'm going to show you some very exciting results. We actually confirmed our hypothesis of lower GABA and higher glutamate in ACC of OCD patients. And when we combine these neurometabolites to GABA to glutamate ratio, we can see that the difference between OCD and healthy volunteers is very large. And in addition to finding these differences in neurometabolites, their concentrations were also associated with behavioral performance, including the dysfunctional checking, but also a bias towards habitual over goal-directed behavior. And to measure the latter, we used a contingency degradation task, which basically manipulates the relationship between actions and their outcomes or consequences. by degrading or uncoupling them. And persistent behavior is seen as a bias towards habitual rather than goal-directed responding. And what you can see on this slide, on the y-axis is the difference between habitual and goal-directed degradation. And on the x-axis, you can see the GABA to glutamate ratios in ACC and GABA ratios in ACC. And these positive relationships, they were found only in OCD patients, not in healthy volunteers. So what these findings suggest is that ACC is not only implicated in checking, but also in adjusting the balance between goal-directed and habitual behavior. But they also suggest that checking is a consequence of excessive habitual behavior. So to summarize, only schizo-OCS group showed dysfunctional checking, and this behavior was correlated with deficits in special working memory, but also their clozapine dose. And this was despite the fact that both schizophrenia groups showed similar executive functioning deficits, such as special working memory, and they had a similar dose of clozapine and the same treatment duration. For our 70th study, we successfully confirmed our hypothesis of higher glutamate, lower GABA, and GABA to glutamate ratios in ACC of OCD patients. And these neurometabolites, they were also implicated in dysfunctional checking and habitual behavior in OCD patients. And of course, the question still remains whether we would find the same neural deficits in the schizo-OCS patients. The answer is maybe, but in order to be able to answer this question with a high certainty, we do need a 70 study in these patients. I would like to thank my supervisor for always being there for me, no matter how busy he is, and my co-supervisors, especially Dr. Fernandez, who also helped us with the recruitment of schizophrenia patients, and our collaborator, Professor Ed Bullmore, and of course, Mental Health Research UK for supporting this PhD. And without your support, none of this would be possible. So thank you so much.
Great. Well, thank you very much, Marjan. Another super talk. Amazing to see, I think, results at all from 7T. But yes, such stunning results, very important.
Thank you.
We've got some questions. Gemma, first of all.
Hi, Maria, congratulations on such a great study. And also to your supervisors. This is really important research. I was wondering if you've also have looked or are planning or looking at whether there's a relationship to the clozapine exposure and the GABA glutamate imbalance, if you would expect there to be some relationship.
That's a very interesting question, but I'm not sure if I can answer this question without doing a 70 study, but especially because both of these schizophrenia patients, they were on clozapine, but not both of them showed the same obsessive compulsive symptoms. And these findings that we find are related to obsessive compulsive symptoms. So for OCS, we do find lower GABA, higher glutamate. Mm-hmm. I suspect that in schizo-OCS patients, we might find the same deficits or the same concentrations of GABA to glutamate. And although there have been findings showing the same deficits in GABA, I suspect that we would find lower GABA concentrations in schizo-OCS group compared to the other schizophrenia group on clozapine.
Thank you.
Sorry, I do need another 70 study to answer your question.
On the treatment question, you mentioned that doses of clozapine were similar and you thought about it and controlled for it, but were there any other treatment differences in the group with OCD? So were they having their OCD treated with SSRI, for instance?
So I have to check the medications, but I don't think there were differences because many of schizophrenia patients, they also have depression symptoms if they don't show obsessive compulsive symptoms. So they are being treated for depression. And aripiprazole is another medication that is prescribed to these patients, these schizo-OCS patients, but it is also an antipsychotic medication. So there were also patients in the pure schizophrenia group that did not show the obsessive compulsive symptoms that were being treated with SSRI or aripiprazole. So there were no, I don't think there were differences there, but I do need to check the numbers exactly. But from what I remember, I don't think there were differences there.
Yeah, it might be something that a reviewer would ask, but your answer led me on to another question, which was about whether there are other phenomenological differences between the schizophrenia OCD and schizophrenia non-OCD. So the OCD difference, does that overshadow other phenomenological differences between the two groups? More negative symptoms, for instance, more depression, more anxiety.
Right. So in the beginning, I did talk about our publication in 2019. We found higher positive and depressive symptoms. And actually in this sample, we also replicated the same findings. We found higher positive and depressive symptoms. These patients were more anxious. They showed higher anxiety, but I'm not sure if these findings are have started after clozapine, or if these patients before clozapine treatment were in general more depressed or showed a more severe schizophrenia.
I suppose I'm thinking of alternative reasons for your results. So was it drug differences? No. Was it other phenomenological differences? Probably not. Samuel.
Yeah, great talk, really interesting.
Thank you.
I was just curious about a couple of things. I mean, I was really impressed by your nice small voxel in the ACC at 70. Very nice.
Thank you.
Were you requiring both? Did you have to edit to get GABA, or like what sequences were you using with the MRS?
No, we didn't. We used semi laser.
Oh right, okay.
Yeah.
And you were able to get both GABA and glutamate together in this.
Yeah. Yeah, we could differentiate them in the same voxel. Okay. But we did do 27 pilot scans with different voxel sizes and locations, and then this size and location gave us the best signal. And it was also mostly reported in the literature for the symptoms that we were interested in.
Cool, thanks.
Any other comments or questions? No, doesn't look like it. So as Anne-Marie Miller has put in the chats, they were 3 great presentations. So thank you, Marjan. Thank you, Samuel. Thank you, Jessica. It's an important session within the conference, this one on schizophrenia. Given John Grace, one of the founding trustees of Mental Health Research UK, his particular, or the late John Grace, his particular family interest in schizophrenia resulted in the John Grace Scholarship, focusing on schizophrenia. So I think all speakers did very tremendous credit to his memory. Thank you very much. So we've got a couple of minutes before we'll be swept back into the plenary session. Does anyone else have any general comments or further questions to any of the speakers?
I'll just pop in now. Marjan, I'd be interested to hear what your postdoctoral work is going to be focusing on.
So I'm going to continue to finish these studies and publish the work that I was doing during my PhD. So this is at least the plan for the next few months. But in the next few months, I will also figure out what I want to do afterwards. It's going to be in the same direction. Okay, I just would like to, especially finding these exciting results made me more excited about academia. So I would like to finish what I started.
Well, that's really good to hear that Mental Health Research UK has given you this opportunity and also piqued your interest.
Yes, and I'm very grateful for that. Thank you.
I just wanted to say I thought they were great talks, and particularly, you know, the ability to adapt in the face of the challenges of the pandemic. You know, absolutely stunning, and yeah, no. So I was very impressed and very proud proud of you as our scholars. So well done.
Okay, well, let's consider the session closed and see you in a couple of minutes when we reappear in the plenary.